Hello everyone from Sydney, Australia. My name is Paul Middleton and I'd like to thank you for the invitation to present to the conference tonight. Thanks Brian McNally and the other conference organisers. Now, I planned to be there, unfortunately, but like for many of us, COVID-19 has interfered and I'm unable to travel from Sydney to California. But even so, I'd like to talk to you about cardiac arrest in the time of COVID in Australia. I'll just share my screen. So as I said, my presentation tonight is about resuscitation, cardiac arrest in COVID-19, things that will be in common with all of us and things that will be slightly different in Australia. I want to talk today though about advanced life support, basic life support, cardiac arrest management in COVID and the differences between before and afterwards.
Jack, can you hear me? Jack? Help! Help! What should I do?
So, resuscitation and advanced life support, as we're all used to it. And this is the algorithm for basic life support pre-COVID. Looking for danger, make sure that we're not affected ourselves, checking if the patient is responsive, sending for help because none of us like to work alone, and then opening the airway and evaluating for normal breathing for no more than 10 seconds. And of course, if they're not responsive and they haven't got normal breathing, they're in cardiac arrest. Our immediate action then would be to start CPR, attach a defibrillator, and defibrillate as soon as possible, whether it's looking at the manual trace on a manual defibrillator or whether it's being prompted by the AED. In our pre-COVID-19 cardiac arrest management, obviously high quality CPR, 100 to 120 a minute, it's a third of the depth of the chest, and at least 75 to 80% of compression fraction. Defibrillate as soon as possible, as soon as you recognize a shockable rhythm. Adrenaline and amiodarone is really the only drugs in CPR. Coached is compressions continue, oxygen away, all others stand clear, charging. And then when the defib is charged, hands off with a challenge response to say I'm safe, evaluate the rhythm and then defibrillate or dump. So what's changed in COVID-19? Well, this is actually from the first time I gave this presentation, which is over a year ago, I think around March, April 2020. And you can see here at that time, 15 million cases across the world and 635,000 deaths. And this is today. Too many people for bubbles anymore, I'm afraid. And you can see the darkest areas, unfortunately, the US and areas in South America, Russia, the UK, Europe. Australia is the next in line. And for us today, we had 600,000 confirmed cases and just over 2,000 deaths in total. Our immunisation rates are pretty good. In New South Wales, we're at about 95% double vaccination. You can see there's almost 43 million total doses administered for a population of just over 24 million people. So in terms of resuscitation, what's the difference? Well, the difference really between then and now is all about us. This is us in 2022 wearing our full PPE. You can see that we've worn it so long now that instead of just the sort of safety goggles, we've even got to the point now where we're wearing prescription safety goggles because we're so used to wearing it. And I think in celebration of that, I'm just going to put mine on now. In 2020, these were the screen grabs and the headlines that I was seeing at the time. And this is the tragic loss of life in the early days of the pandemic from doctors, nurses, paramedics, health workers who had died as they didn't sometimes even recognize that the COVID-19 infection. And these are the headlines from around the world. And in Australia, we had headlines like this, where the Dan Andrews, one of the premiers of one of the states, was widely criticized for going into lockdown. But you can see the commentary in October last year from the World Health Organization Director General was that COVID actually may have killed up to 180,000 healthcare workers across the world. So in 2022, This is from yesterday. And what you can see is that new cases, 38,000 in fact today, there were 45,000 in New South Wales. So we've just entered the era of Omicron. And these are some headlines from now. The Omicron is making some headlines all over the place, but certainly in Australia, the exponential growth in the cases is causing major problems for all the hospitals. And what that's actually done is that even the decisions about when you isolate, how long you isolate for, have been changed largely to make sure that we're able to be available to manage the patients coming into ED, whether or not that would have been supported by the science no more than a week or two ago. So here's what we hope for. Of course, we look for a population that's completely masking up. Unfortunately, is that you've had many people who've decided that masks are a political statement, and that it's much better not to be wearing a mask because clearly suppression of your choice. So what's changed in ALS? Well, one of the biggest things for us is the identification of aerosol generating procedures, AGPs. And AGPs are the sort of thing that we would actually do routinely and regularly for our patients pre-COVID, but we have to think about things very differently now. So ALS COVID style is a little bit different. You can see there's our first responder in those previous circumstances, that he's now going to be appropriately protected. I want you to watch the differences between the first video and this one.
Continue compressions, oxygen away, everyone else away. And we're charging. Okay, so shockable rhythm, we're shocking. Please.
So what are we doing that's different? Well, first of all, is that all of our intubations, when possible, are done in a negative pressure room, whether it be in a resuscitation area or another area of the emergency department. Our algorithms changed somewhat as well, and now we're using the pandemic algorithm. I'll just go through that one by one. And the first thing we're doing really now is thinking carefully before we start resuscitation about whether it's appropriate or not. We have airway generating procedure, PPE, put on before we enter the room, and we cover the patient's mouth with a surgical mask or something else, and call the resuscitation team as soon as possible. There are no rescue breaths given, and we defibrillate as soon as we assess the rhythm. We also move essential and non-essential staff out. You'll see in that previous video that the first responder was asked to leave the moment that the properly protected team had taken over. We also often use mechanical chest compressions. The Lucas 2 is the commonest used here to avoid, even those are small with compressions of generating aerosols, we still use a device. And insert an LMA, or much more ideally, to intubate the patient. And then we discuss, once again, the senior staff about ongoing treatment when we secure the airway and ensure the family are cared for. So just going back to that video you saw there, instead of putting the face down by the patient's mouth, checking for a look, listen and feel to see if we're breathing, one of the first responders is checking for chest movement. CPR is being performed here when there's 2 first responders in the room, but with the patient's face covered. The moment the team arrive, they're taking over from the unprotected people, and then you can see that we're defibrillating as soon as possible. The most experienced person is intubating here. We would usually use a video laryngoscope by preference, but also, of course, we can use a manual laryngoscope as a secondary thing. And of course, when this is a patient who's not yet arrested and we're trying to prevent arrest, because many times there are signs that somebody's heading for that with COVID quite a long time beforehand, we tend to give them their induction drugs sitting up, or at least at 45 degrees, and lay them down afterwards. We use a bougie every single time that we intubate somebody. We pass the tube over the bougie and then take the bougie out through gauze and hold on to it so that we don't flick the end around and flick various stuff around the room. And then when the circuit is complete, there's a closed circuit and there's no chance of aerosols, then we restart CPR. Finally, I just want to talk about the actual impact of COVID-19, not just on the processes that we use in cardiac arrest, but actually in the system itself. In the emergency department, there's been evidence to show that things have changed quite markedly for us. The productivity over an approximately 10-hour shift for senior physicians has reduced by about half from previous data. There's 10 over 10, almost 11% decrease in productivity for each junior physician they're supervising. And that wasn't affected by bed access. But our ability to manage our own patients obviously varies on multiple factors, particularly our load of supervising. And supervising people in COVID-19 reduced the ability to see patients by half. And then, of course, there is the pre-hospital setting. And this paper discusses the impact of COVID-19 on cardiac arrest and the pre-hospital setting. This is actually my hospital with ramping of ambulances. And it showed that in this setting that the incidence of out-of-hospital cardiac arrest actually didn't differ during the pandemic period, but the resuscitation by EMS differed quite markedly. And arrests in public locations also decreased by about 50%, as did the initial shocks by public access defibrillators and first responders. And there was an increase in the delay to key interventions such as defibrillation. And survival to discharge in this actual study decreased by 50% during the pandemic period. So in summary, we need to assess the risk and the benefit of resuscitation and cardiac arrest in COVID. We use negative pressure rooms by preference. We have continuous high quality CPR and we intubate early. We assess risk and benefit. We make decisions. Although we've got minimal knowledge, we have to make decisions early, and we work out whether the arrest is because of COVID rather than with COVID. In the pre-hospital setting, survival still depends on first responder and bystander actions in just the same way they did before. But most importantly, we need to protect ourselves. So it's PPE, PPE, PPE. Thank you for listening, and I hope the conference goes well.
Hello, it's an honor to be part of the CARES Paris meeting in San Diego, though I'm in Copenhagen at the time. Due to COVID, I'm not able to go to San Diego, unfortunately, but I'm happy to contribute to the program and to the discussion. Please find my affiliations, CEO of EMS at Copenhagen and Copenhagen University, and also contact information if you want to collaborate with us in Copenhagen or you need further information from me or this presentation. My agenda for this presentation will be, I'll start with one case from Copenhagen, then a bit about our Citizens First Responder program, and then data on impact on practice and survival. Finally, some information about hospitalization, ICU admittance, and vaccinations in Denmark, and then a good news about EMS 2020 in Europe. And then you get additional information if you want to. Last time in San Diego, I was in 2020, the beginning of 2020, just before COVID. And I was presenting some preliminary work we had about video streaming during 911 calls. Now, 2 years later, we have published 4 scientific papers on this, showing that it does make the dispatcher's assessment of the situations much more precisely, and it also improves the bystander CPR quality due to video guidance. But now it's about cardiac arrest and COVID. And the world's most witnessed and watched out of hospital cardiac arrest was probably taking place during COVID in Copenhagen last year. You can see that on YouTube, but I'll just share with you some few pictures. The collapse, the alert, the response, the worries, leaving the scene, and seeing that Christian Eriksen is alive, he's awake, and he's actually doing fine today. So this was a cardiac arrest during COVID, witnessed by the whole world in Copenhagen. And COVID changed the role of EMS and the future of EMS as well. We are frontline personnel. We are part of our community, and we are here for our community, and we can do much more than we initially thought. For instance, in Copenhagen, we started testing the population, and we also started vaccinating the population. Though this became a role of EMS in our society, as in many other places. And going back to cardiac arrest, I first want to introduce you to our very good results from the previous years, so that you can compare with COVID 2020. We were in the upper class of outcome together with Seattle, King County. The blue line is Copenhagen EMS survival per 1 million people. And you should have that in mind when you see the results from 2020. Part of our success is the National AED program. We have 20,000 AEDs for public access defibrillation for a population of 6 million people. And we have a Citizens First Responder program with more than 120,000 volunteers that we can alert for out of hospital cardiac arrest. They go out for not only cardiac arrest in public places, but also in private homes. And they reach the victim in 40% of the cases before the ambulance arrival. And now to the data from 2020. As you can see, the graphs are in Danish, but I'll try to explain it. It's the same pattern. We start with 21, year 21, and then 2020. And then you can see the bars are the cardiac arrest per 100,000 inhabitants, and the lines are the total number of cardiac arrest. So 2020 was very similar to 2019. We didn't have an increase in out of hospital cardiac arrest. We didn't have a decline in number of cardiac arrests either. The first responder or bystander CPR rate in percentage was still 80%, which is very, very high, and it remained very high. The bystander use of AED, the graph shows in all of cases, second in public places, and the lower one in private homes. And you can see there was about the consistency in the number of use of AEDs in these three cases in 2020 as well. A small decline, but not significant. And if you go to ROSC and 30-day survival, as you remember, we are high. We have very good results in Copenhagen. But here you can see the change from 19 to 20. There was a bit change, but it was not significant. Actually, we expected it would be lower, but it wasn't. So we are still in the upper class for good results in out-of-hospital cardiac arrest. And if you compare the Utstein population, meaning the witnessed shockable rhythm, you see the same results, no decline in 2020 compared to 19. Still high and good results. So in summary, we have the same number of cardiac arrests. We have the same distribution between private and public places. We have a total survival rate of 14% for all cardiac arrests, and the total number is the same as well. The bystander CPR rate is still high, and we have a lot of AEDs available for public access defibrillation. So in summary, the same incidence, meaning that we have a very good registration. We have 81 cardiac arrests per 100,000 population. The bystander rate is very high still. Survival rate to hospital and 30-day survival is also the same as previous year. Survival for all in total is 14%, equivalent to 11 per 100,000 inhabitants. And the survival for Utstein benchmark is 42%. And 88.7% of public access defibrillation is done before arrival of the ambulance services. Let's then go to COVID cases. These are confirmed cases for our population since the beginning of COVID. We used to talk about 2 peaks at the beginning and in between 21 and 22. And now we have a 3rd peak, end of 21 and beginning of 22. But that's a huge peak we have right now. A lot of confirmed cases, despite we have social distancing, despite we have restrictions as well. But it doesn't reflect a lot of hospitalizations, as you will see. We have a national dashboard here. And what is important is to see we do a lot of PCR testing. We do a lot of antigen testing as well. And we have nearly 1 million confirmed cases in Denmark for the population of 6 million people. However, the number of deaths is 3,385 for 2 years period, meaning 0.4%, which is low, very low actually. So we are doing a lot of testing, we're doing a lot of vaccination, and we have low rate of deaths due to COVID. This is a graph showing vaccination in the European countries, and Denmark is the 2nd highest one. We have 76% of the population fully vaccinated. The one in the upper class is Malta and in the Mediterranean. If we go to hospitalization right now, meaning the last period of 21, those who are in hospitals are actually patients with COVID. So if you are hospitalized with COVID, you are probably not vaccinated. If you are vaccinated, the incidence is very much lower. And also when we look at intensive care unit, if you are admitted to intensive care in the hospital, you are probably not vaccinated. And those vaccinated is a low proportion compared to the proportion in general. And our Danish clinical quality program reveals that 25% of our patients in ICU are due to COVID. Half of them are on ventilators still, and mortality is 28%. Surprisingly, 1/3 is without comorbidity, but it also reveals that about 50% of the ICU patients are not vaccinated, despite it's a small percentage of the Danish population. They're also younger, much younger. And what is interesting for those of us who are vaccinated, only few patients in ICU with 3 vaccination. So in summary, COVID changed our practice. EMS changed and has adapted new roles. We had expected lower survival rate in 2020 and in 2021 due to COVID, due to restrictions, due to longer response time, and due to precautions. But we didn't see that. And I think the reason we didn't see that is because we continued our Citizens First Responder program in Denmark. Half of the countries in the European Union didn't continue their program. We did. And it probably explains why outcome is much better than expected. And finally, I want to invite you all to the European EMS Congress 2022 in Scotland in May, in a few months. Thank you.
Hello, I'm KJ Song, working as an emergency physician at Broadway Medical Center in Seoul, Korea. It's a great honor to me to participate in this CARES Paros meeting as a speaker. Thanks to Brian and Dr. Mark Song. I was also going to attend this San Diego meeting, but I'm so sorry I couldn't join this time. I sincerely hope that we can have a face-to-face discussion next time. Okay, what I'm going to talk about today is, as you can see, I will show you the COVID-19 and OHCA instance in South Korea first. In 2020, there were 48,844 COVID-19 patients occurred in Korea. And in 2020, there were 31,417 patients, OHCA patients occurred. And in 2019, there were 30,279 OHCA cases occurred. This is a graph showing the number of corona patients and cardiac patients by week. There is no change in OHCA patients during 2019 and 2020. So compared to other countries, the lower instance of COVID-19 in Korea minimize the effect of COVID-19 on the occurrence of OHCA with it. And OHCA survival rate trend in Korea shows that the survival discharge decreased from 8.7% to 7.5%. The CPC 1 or 2 rate also decreased from 5.4% to 4.8%. You can see. This is the graph showing the COVID-19 cases and the OHCA survival to discharge rate. This is also COVID-19 patient to good neurological recovery rate. We check the cross correlation between the change of COVID-19 patient number and the survival rate or good CPC, but there were no significant relation. So we can conclude the survival outcomes of OHCA during the COVID-19 pandemic was getting worse on a daily basis in Korea. So I think there will be another cause to decrease these survival outcomes of OHCA. The ROSC rate of OHCA patients, including pre-hospital ROSC, you can check the decreased ROSC rate itself from 34.3% to 32.1%. And there is no significant difference in PCAS care, post-cardiac care during this pandemic period. And the survival outcomes of OHCA patients with ROSC get worse during 2019 to 2020. You can check the survival discharge rate from 25.3 to 23.2%. Compared to 2019, the AG, the 0.8 year increased, and the public place rate was 1 percentage point decreased, and bystander CPR rate 2 percentage point increased during this period. And compared to 2019, response time 1 minute increased, and the total pre-hospital time was 3 minutes increased during this time. You can check here and here the response time and total pre-hospital time. We analyzed from 2015 data to 2019 data. When the response time increased from 1 minute, there was 1 percentage point less chance to survive. The 1 percentage point decreased the survival rate. But the response time and total pre-hospital time, the distribution get worse in this corona pandemic period. You can see the right shifted graph, this response time distribution show they move to right, and this total pre-hospital time distribution also right shifted. You can see. So reduced early ambulance response rate and over pre-hospital time delay contributes to worsening the survival outcomes. But this situation is getting worse because more COVID-19 patients, because we had some policy with corona. Then we released a new isolation rule or social distance policy from November last year. Then we get more COVID-19 patients. So the first pandemic period, it's a very significant situation now. This is you can see the graph ROSC rate with COVID-19 patient. This is the first pandemic, this second pandemic, third pandemic in South Korea. During that period, the mean pre-hospital ROSC rate, you can see that decreasement during that COVID pandemic period compared to other period. So ambulance waiting to respond to vaccine side effect and the traveling 5 hours with an ambulance patient. This is some news topic in South Korea. So they all reported this very serious situation with COVID-19 patient, and our EMS or emergency medical circumstances situation. So in summary, in 2020 COVID-19 pandemic, OHCA instance of Korea is stationary and PCAS care stationary, but bystander CPR rate increased, overall survival discharge decreased, and response time and total pre-hospital time were delayed. The situation is getting worse in this year, the end of last year and this year. So COVID-19 pandemic has worsened, and pre-hospital delays are on the rise. So we need more good solution about this. Thank you for your attention. This is the end of my presentation. Thank you.
A very good morning, one and all. My name is Andrew, and I'm an emergency physician from Singapore. Today, I'm pleased to share with you some of my perspectives on how the cardiac arrest epidemiology has been affected by the COVID-19 pandemic, both from a Singapore as well as a global perspective. it's been more than 2 years since the world has been journeying with this COVID-19 pandemic. It has been a series of ups and downs, and so far there is still no signs that the virus is really going away. It is therefore, I think, 2 years on, a very good time for us to take a step back and take stock of the situation and examine how the pandemic has been affecting our emergency care systems. Now, cardiac arrest is a fantastic disease for us to adopt as a lens through which we can actually examine how a public health event like the COVID-19 pandemic, has on the entire emergency care system ecosystem. And we hypothesize that the pandemic has two effects on the cardiac arrest epidemiology. First is that incidence is increased, and secondly, that outcomes are poorer. It is perhaps easier to understand how outcomes are poorer because, in the whole chain of survival, every single link can possibly and are likely to be disrupted by the pandemic. As for how the pandemic has influenced incidence, it's perhaps useful to adopt the perspective, of how, the public health traditionally views disease prevention using primary, secondary, and tertiary prevention. Primary prevention is relevant in this case because of the breakdown of primary care services where patients would usually be able to keep their chronic illnesses under control, now would have their diabetes, hypertension going haywire, and as a population be at increased risk of acute diseases like cardiac arrest. As for secondary prevention, that is early detection of diseases that occur. Firstly, patients delay going to the hospital for mild symptoms, where we will usually see patients present with angina, they now come with cardiac arrest. And secondly, there's less chance of a cardiac arrest being recognized early and having the EMS activated early because they now occur at home more than in the crowded public spaces. As for tertiary prevention, that is preventing complications by instituting early and good treatment, that we can understand through the chain of survival. And therefore, our two hypotheses that incidence is increased and outcomes are poorer. As for why these are so, it is perhaps easy and convenient to take a simplistic kind of perspective and attribute many of these to just, patients catching COVID and, getting respiratory arrest. But us being emergency care physicians and resuscitation scientists, we're all trained to adopt a systems-based approach to studying problems. And it is then easy to see how the pandemic can have multifactorial, a very complex kind of a causal relationship with this with incidence and outcomes. We've already talked about how incidence could be increased through the disruption of primary healthcare, through the alteration of health-seeking behavior, and also through reduced self-care. Now, as for outcomes, this could then be in turn, be related to how infection control measures in our healthcare workers could have led to reduced resuscitation performance. And also there is a need to ration scarce resources like ventilators and ICU beds. And finally, the pandemic occurring at home more than in public areas, compared to previously, would necessarily mean that there are less bystander actions. There's just less chance that there is a bystander around who knows how to use a defibrillator or how to deliver CPR, for example. So we sought to test these two hypotheses using two study designs, and I'll talk about each of these in detail later on. The first is a retrospective cohort study in Singapore, and secondly, the second study is a meta-analysis of the global data. In the first study, we used the Singapore data from the ROSC Registry to perform a retrospective cohort study comparing the pandemic period with the pre-pandemic period. The pandemic period being the first half of 2020 and a pre-pandemic period being the first half of 2018 and the first half of 2019. We used logistic regression to model the effects of the pandemic on various outcomes. On the right-hand side, in the population flow diagram, you can see that there are some signs that the number of cases have increased. If you follow my cursor, in this box, there seems to be a marginal increase in the number of cases per year during the pandemic. And in terms of ROSC, which is our primary outcome, there seems to be a marked drop in the number of ROSC, 130 compared to 160 per year before the pandemic. Now let's go on to test whether these changes are due to chance alone. These are multivariable logistic regression models showing the independent effects of the pandemic, on various outcomes. I would like to highlight three major findings. The first is a 50% increased odds that a case will occur at home compared to the public area. Secondly, is a 30% drop in the odds that a case will receive bystander CPR. And finally, in terms of the primary outcome of ROSC, there is more than 30% reduction in the odds that a case will attain ROSC. And therefore, you can already see evidence that outcomes are poorer during the pandemic, at least in Singapore. But now let's look at the global setting. So in the second study, this was a meta-analysis that we recently published in the Annals of Intensive Care. This was, we performed a search of 5 databases, and we included studies that compared the pandemic period with a pre-pandemic period. And on the right-hand side, you will see that out of 550 articles, we have included 20 articles. There are 2 pertinent findings that I wish to highlight. This is the first. In the first pertinent finding, that is that of the meta-analysis for mortality, we do observe a pooled odds ratio of mortality of 2 times compared to the pre-pandemic period. And a visual inspection of the forest plot will show that there is a consistent pattern that in all the community studied, there is at least a trend of outcomes being poorer. Now let's look at the second pertinent finding, and that is that of increased incidence. So in the left top corner, that is the blue box, it shows that the pooled incidence in a pre-pandemic period was about 90 per 100,000 cases, whereas the pooled incidence during the pandemic period was 110 per 100,000 cases. So increasing from 90 to 110 per 100,000 cases, is that statistically significant? We tested it using a z-test, and indeed it was, and it corresponded with a 40% increase in incidence. And therefore, in conclusion, we did show evidence, both in Singapore and from global data, that incidence has increased, that outcomes are poorer during the pandemic for cardiac arrest. And I would like to emphasize this point, that it is important to adopt a comprehensive systems-wide lens to look at how these public health events like pandemics can influence our emergency care systems, and that it is useful to adopt cardiac arrest as a prototypical condition in which we can examine the various aspects and dimensions of the emergency care systems. With this, I thank you for your very kind attention.
Good morning, everyone. Continuing the discussion, we will present the global impact of the COVID-19 pandemic on resuscitation practice in the United States. My name is Kelly Robinson.
My name is Udit Prasad. We are EMS fellows from Emory University School of Medicine.
Our objectives for today's presentation include an update on CARES participation across the nation, an update of out-of-hospital cardiac arrest, airway management, and resuscitation operation during COVID-19, the impact of COVID-19 pandemic on survival outcomes of out-of-hospital cardiac arrest in the United States.
First, the update on CARES participation across the nation. This is the current CARES participation, which includes a total of 31 states across the US. As shown here, the blue states are the participating states. CARES footprint represents 51% of country's population base. This is the latest complete data set of CARES Registry. It includes 1,741 EMS agencies, 1,876 hospital contributed data to CARES. And this graph reflects an increased annual call volume submitted to CARES since 2006. The CARES national report will be posted on the website mycares.net.
Update of out-of-hospital cardiac arrest, airway management, and resuscitation operation during COVID-19. Airway management and out-of-hospital cardiac arrest. As the pandemic continues, implementing early airway strategies while balancing providing quality CPR is key. Airway management protocols across the country vary and consist of early intubation versus utilization of supraglottic airway devices or bag valve mask ventilation with a tight seal. Particulate absorbing filters are recommended with each device. All guidelines emphasize minimalizing exposure to EMS providers. In July 2021, the American Heart Association released an interim guidance for emergency medical services management of out-of-hospital cardiac arrest during the COVID-19 pandemic. The guidelines recommend continued practice of the foundation of resuscitation with quick recognition of cardiac arrest, alerting EMS, initiating chest compressions, and early defibrillation. Additionally, the AHA highlights the low prevalence of COVID-19 among out-of-hospital cardiac arrest and the seemingly lower risk of SARS-CoV-19 transmission with hands-only CPR or public access defibrillation. Telecommunicators should prioritize CPR coaching for the bystander to deliver hands-only CPR for an adult patient, with the addition of rescue breathing, if willing and able, for infants and children.
Next, the CARES National Dataset comparison from 2019 to 2021. In comparison to 2019, the red solid line representing 2020 data and the blue solid line representing 2019 data, which show an increase in both time to defibrillations and time to CPR starting in March 2020. These pie charts show a decrease in sustained ROSC in the field, 30.7% in 2019 in comparison to 27.1% in 2020. Also, an increase in field termination of resuscitation, 42.4% in 2020 compared to 36.4% in 2019. Overall survival decreased following the start of the pandemic in March 2020, and this effect continued throughout the year. Survival rates decreased, including survival to hospital admission, survival to hospital discharge, and a decrease in good to moderate CBO performance category.
This chart depicts CARES 2021 preliminary data. The 2021 complete data will be released in April 2022. The number of public arrests and non-traumatic arrests increased as we have more participating sites that contribute data to CARES. Bystander CPR and shockable rhythm have decreased from 2019 to 2021, with the smaller difference from 2020 to 2021. The data highlights sustained ROSC, the greatest predictor of overall survival rate, continuously decreased in 2021, with 30.7% in 2019 and 26.9% in 2021. For public AED use, data thus far shows potential recovery to the pre-pandemic years, with 10.1% in 2021 and 12.2% in 2019. Impact of COVID-19 pandemic on survival outcomes of out-of-hospital cardiac arrest in the United States.
This is the CARES COVID publication in JAMA using 2019 and 2020 data. The objective of study was to assess the association between the COVID-19 pandemic and out-of-hospital cardiac arrest outcome, including in areas with low and moderate COVID-19 disease burden. Cases were geocoded to US counties, and the COVID-19 mortality rate in each county was categorized into very low, low, moderate, high, and very high. Shown in this table, the primary outcome, sustained ROSC, was 29.8% in pre-pandemic and went down to 23% in 2020. Also, this outcome was lower in 2020, even in counties with lower mortality rate. The secondary outcomes include the rate of termination of resuscitation. Overall, the rate of TOR was higher during the pandemic. A similar pattern was noted with regards to TOR, including the counties with lower mortality rate of COVID-19. Lastly, a decrease in survival to discharge, another secondary outcome, was observed in the communities that were moderately to severely affected by the COVID-19.
In conclusion, out-of-hospital cardiac arrest, resuscitation, and airway management remains changed from pre-pandemic years. Lower rates of bystander CPR and public AED use and higher rates of termination of resuscitation were observed during the pandemic. COVID-19 continues to adversely affect out-of-hospital cardiac arrest outcomes, including ROSC, bystander intervention, and survival to discharge. Thank you.